So a large part of work that you would do at SGPGI is related to patient care, and you would certainly be required to document whatever patient care activities you undertake, whatever treatment you impart to a patient. You would be seeing patients in the OPDs, and then you would be admitting them, discharging them, and unfortunately, a few of the patients would die under your watch. And so, it would be your duty, it's your responsibility to record all the various happenings uh, during their outpatient or inpatient treatment. And so you would be required to prepare visit summaries or discharge summaries, and then at certain times you may have to make death summaries too, or death certificates. The death certificates will be dealt with in rather great details by Dr. Afzal Azim later on, but I would talk about what is expected of you when you are preparing the discharge summaries and death summaries uh, at SDPGI, or perhaps at any hospital. So these are all essential parts of medical records of a patient. Medical records, by definition, are nothing but systematic documentation of the current, the past medical information of a patient's condition, the treatment imparted, and the outcomes which were achieved, and what future advice is given to the patient. And discharge summaries or case summaries are the visible face of these medical records. You may have very elaborate and extremely well kept medical records in your own institution, but the patient would not be able to see it. The outside world would not be able to see it. What the outside world and the patient and the family members would see is what you hand over to them in form of a case summary or a discharge summary. So, needless to say, you have to provide them with a appealing, most appropriate format of these documents, which can be called discharge summaries or death summaries or case or visit or follow-up summaries. So in patients who are, I mean, these, as I said earlier, these are nothing but a record or a systematic documentation of all that was done to a patient in the outpatient or while the patient was admitted in the inpatient areas or the wards, the treatment given, the investigations carried out, the progress which you achieved, a record of that progress, and these are vital for continuity of care or maintaining continuity of care of a patient. A patient may today be admitted with you, or may have been seen by you in the OPD. Tomorrow, the patient may require to go to a different hospital, and the doctors at that hospital or a second facility, another facility, would need to know what all has gone on with the patient's treatment earlier, and this record would provide that doctor exactly the what is required for him to know. Think for yourself. Often you would be seeing patients referred from other hospitals, and unless the patient carries appropriate records, including the discharge summary or the case summary or visit summary or follow-up summary, you would be totally lost. You would be searching for all that information regarding what all treatment has the patient undertaken earlier on. And these documents assess or assist the assessment of ongoing treatment. They help you ascertain progress or deterioration of a patient's condition while on treatment. These are also meant to be used not just by doctors, but also by pharmacy, by other paramedical teams, and even for I mean, these are documentation for posterity for use by other doctors and other teams, including yourself later on, as well as by the insurers or healthcare authorities to determine the claims the patient may be making for insurance or reimbursements, etc. So, what are the various components of a visit summary or a follow up or discharge summary? It must contain the demographic data, the essential demographic data of the patient, so that you can identify, or anybody who's looking at this document can identify which patient are we talking about. The name of the patient, the patient's father's or husband's name, date of birth, a case records number, or a unique number, which is the registration number of the patient in the hospital, and some other identifiers, including the address, the phone number. It should also record the reason for visit or hospitalization, visit to the OPD or admission to the hospital. It should, the discharge summary should also, or follow-up visit summary should record the significant findings in history and clinical examination that were found during this encounter with the patient, what procedures and treatment were planned and then carried out or executed have to be recorded there. What was the patient's condition on arrival, and then what was the condition at discharge, or at the end of the OPD visit? Was it unchanged? Did the patient improve? Did the patient deteriorate? Or in that event of death, the condition or conditions leading to death. Besides, this summary should also provide the patient and the family members specific instructions relating the treatment, the ongoing treatment, the follow-up visit, any investigation those need to be which are needed to be done, and whatever other instructions the relating diet, nutrition, physiotherapy, and whichever other things that you think are important. And this summary must also have the physician's or the doctor's signature. And in case these are electronically generated documents, then it must carry the electronic signature or a statement saying that this is an electronic document and does not require a signature specifically. So I think a visit summary or a discharge summary needs to be complete as much as possible and should be adequately extensive, so that whatever required details of the patient's condition, the treatment given, and the progress achieved are recorded there. This discharge summary should address all the issues related to the clinical and investigative diagnosis, the treatment, referral, consultations, the treatment and plan of care given to the patient with justification. Why were those done or why were those planned? The operation, if any, or any intervention, if any, done, the justification for that, the procedure performed, any lapses or adverse events which may have occurred during the course of such an operation or intervention, and then finally the outcomes. Did the patient improve? Did the patient deteriorate or stay unchanged? So here is an example. I'm sure during these few weeks of your working here, you would have made a few of these already, or if not made yourself, you would have seen a few of these being made by your colleagues. Now, look at this discharge summary carefully on your screens. It has the CR number. I mean, this is generated automatically by the hospital information system. But there are number of fields that you need to be aware of, and you would have to enter them into the right places and on HIS, so that these fields become populated on the discharge summary on HIS. So it has the CR number, the name of the patient, the age, gender, department where the patient was admitted. In fact, this is the name of the department or the ward from where the patient is discharged. So the patient may actually have been admitted elsewhere, but may have been shifted to a different ward, but the department and the ward names remain, or the which are printed are those of where the patient was discharged from. In case a department has number of units, the unit's name, ward and bed numbers. There is an admission number generated for every patient who is admitted, and this unique admission number is important for uh, uh, later on in posterity knowing about these details. The, the date and time of admission, the date and time of discharge, whether the patient's admission was a normal or an emergent or special or VIP, who was the consultant under whom the patient was discharged, or admitted, and what was the kind of discharge. Was it a routine discharge or a lama or um, absconder or whatever? Patient's address. Unfortunately, these are things which are populated automatically from the data which are collected at the time of the registration of the patient. But it is not impossible to improve on this. There are ways of completing whatever information may have been missing. Then underneath, this is all that you have to fill in. The patients, I feel it's a good idea to start with the name of the doctor who has seen the patient, and in fact, in many units or departments, the name of the residents who have managed. In most cases, number of doctors are involved, so it may not be possible to name all the doctors who are involved with the patient's care, but the important key ones: the diagnosis, the procedure, if at all any was done, on which date was the procedure performed, the patient's salient history findings, the chief complaints, present history, past history, family history, examination findings. And this, on the bottom, you would also see who's the doctor who has discharged the patient and at what time and date was the discharge done. So all these details are important because you yourself would require these details later on, and any other doctor who's looking after this patient in a future medical encounter would require this information. As I said earlier, it's important that you ensure the primary care or referring doctor's name is provided, uh, and the history that you record here should be concise. It's best to itemize the description of patient's initial presentation rather than be descriptive or narrative. It is important that you indicate the pre-existing conditions the patient may have arrived with versus any conditions that the patient developed during the stay in the hospital. Uh, Similarly, in the examination findings, it is best that you include only such most significant findings on investigations. For example, here the crucial investigations based on which you made a treatment plan, and that the treatment plan may have been executed. And then finally, you must include the important developments about the patient of the patient while the patient was in the hospital, but do not be over inclusive. You do not need to document even a minor happening that may have happened, but it is best that you describe what was the course of event, or what was the sequence of events of whatever treatment that was imparted to the patient while in the hospital, and as well as the operative findings or interventional procedure findings and procedure performed. And most important thing is status at the discharge, whether the patient was improved, unchanged, or deteriorated. Now, another important portion of this discharge summary or visit summary is the advice that you give to the patient at the time of discharge. Uh, this should include any instructions about motility, about any exercises or physiotherapy, the diet, what activities the patient is allowed and what are not allowed, what kind of diet the patient is asked to take, any medications that the patient may be asked to take, and the dose, the duration, the number of times the patient has to take those medications, and how many days or duration the patient is expected to continue with that. And then any other information, it's best that we keep them categorized and list them in an itemized way rather than just provide a narrative. The future plan of action of the patient has to be charted out and spelled out very clearly so that the patient is clear about when the patient is likely to be called back to the hospital, or when the patient is supposed to come back to the hospital, what kind of other activities the patient is allowed. The discharge summary must list the phone number in case of an emergency, what the patient can use to reach out to the hospital, to the doctors who have treated him or her. When is the patient expected to come back for follow up? Is the patient needed to make a make an appointment, if it is possible to make that appointment telephonically. All those things must be included. And as I said earlier, it is best that we provide itemized follow-up instruction plan and not just a narrative or everything written as a in one go. Follow-up arrangements, if at all required, must be made, and the referrals, if there have been any, have to be listed and scheduled, uh, and also must include the discharge, the name of the person who has prepared the discharge, the full name, his signature and date. So, in my mind, to my mind, the most important ingredient to for providing or making a perfect summary is the will to provide a perfect summary. If you have the will to do it, you would make time. You would ensure that you allocate sufficient time to this. You would have sufficient time and intention to pay attention to every detail that should go into the discharge summary. It is best that we individualize, make individual documents or discharge summaries and not just copy paste from. It is okay to copy paste some part of the most routine or mundane kind of details, but every patient is unique, every patient is different. So it is best that you individualize these documents and not simply copy paste from a template. And as I said, it is all possible when you allocate sufficient time to this activity. And I often tell my residents that you do it the previous evening, the evening before the patient is about to be discharged. Most patients are discharged in a planned manner. The discharge would be planned a day before or even 2 days before. And so it is not, and then you can prepare the discharge on the HIS, save it, and do not execute it, do not complete the discharge. Whatever you have prepared and saved would stay there on the HIS, and in the morning you just have to do the or give the finishing touches, complete the discharge formalities, and the patient can go home. So this is the checklist for a good discharge summary. The key elements in this include problem that led to hospitalization, key findings and the test results, the final diagnosis. It should include both the primary, secondary, any other ancillary or other diagnosis. The patient comes for treatment for a particular condition. That's the primary diagnosis. The patient may also have number of other ailments, maybe say diabetes and hypertension or CAD. Those are secondary diagnoses. A brief course of the hospital stay, condition at discharge, whether the patient is being discharged to home or being transferred to a different hospital, what medications are advised to the patient to be taking at home after discharge, the follow-up appointments, the proposed management plan, anticipated problems, and if in case those problems arise, what should the patient do in those events, the pending reports, if any. For example, the patient has been operated, sent home on third, second post-operative day, the final histology may be awaited, so it must be recorded on the discharge summary, and some instructions to the patient how to take those, or whether the patient would be provided the same on the first post-operative follow-up. What are the recommendations for any further specialty consultations for this patient, documentation of the patient's education. You may have educated the patient about the patient's nutrition, diet, diabetes care, whatnot, should be documented there. And then a name of a person or a facility or or a center, for example a ward or an OPD, and a 24-hour phone number, just in case the patient develops an event, unexpected adverse event. Death summary, I would not go in great details of, but the death summary has all the components that we have discussed about the discharge summary, except the condition at discharge is no longer a condition discharge. It is a death. The only event that leads to this summary being made is death of the patient. Again, attention to details has to be there to ensure accuracy. And this is a legal document. Both the discharge summary and death summary, these are legal documents based on which a lot of things are decided for the patient. So you must ensure that the spellings are accurate, The address, the Aadhaar number, or the CR number, or any other entries relating the patient are accurate, and there's no scope for any error there. The chronology of events must be listed in the summary, the dates and times, because all these things have medical legal implications. The demographic details, as discussed earlier, the medical condition, investigations, and the treatment meted out should be recorded in a stepwise method, and the outcomes which happened, and the eventual outcome is death in a death summary. But then there are number of intermediate steps or intermediate outcomes which the patient may have had. For example, if the patient had undergone a surgical procedure, so before surgery the patient would have been prepared or may have been investigated or evaluated, then the patient would have undergone a surgery. Post surgery, what kind of deterioration happened? When did it happen? Did the patient require mechanical ventilation? Did the patient go into sepsis or multi organ failure? Whether the patient had a waxing waning course or improving and deteriorating course, and eventually what led to the death of the patient. These are all the things which are required in the death summary. Cause of death is perhaps the most important, the most crucial, the vital part of a death summary. And I am certain Dr. Afzal would deal with this in greater details. But you must make sure that you pay adequate attention to this detail in the death summary. The most important component of relating the cause of death and event of death are the date, time, and location of death. There may be patients who have been brought dead to the hospital, has to be recorded specifically. The patient may have died in a different location, say, for example, in the corridor while being shifted from ICU to the ward. God forbid this happens, but if the patient has died elsewhere rather than at a location where you have examined the patient, all those things need to be recorded. It is essential to state the causes of death accurately and fully to the best of your information and knowledge. The death certificate is the relative's permanent legal record of the death of the patient. It must include the main causal sequence of conditions leading to death. In the first line, in underneath, all certificates are now made on a format or a proforma. The first line of that proforma under the cause of death has to record the state, the disease or condition that led directly to death. The second line should have the antecedent conditions or antecedent causes of death, and you can work your way back through the antecedents to list all those things, and until the time that you reach the underlying cause of death, which initiated the whole chain of events leading to ultimately the death of the patient, which is listed in the lowermost line. And this is just an example of how it is done. So the patient's immediate cause of death may have been rupture of myocardium, which was triggered by acute myocardial infarction. And the patient may have had an antecedent history of coronary artery thrombosis, atherosclerotic coronary artery disease. So these are some of the examples of how you state the cause of death in the death summary. So this is all that I had to talk about relating